All right. Well, it is so wonderful to meet you, Basil. It is just a pleasure after hearing some wonderful podcast episodes that I found where you were the expert guest. And this is a topic that has come up, as I mentioned to you, several times in the past few years working with patients, this chronic cough. And for the patients that have it, as you know, this can be just a really frustrating symptom. And a lot of them have had a really hard time addressing what is actually going on and maybe patients being mistreated. So I'm really excited to dive into the conversation today, but I'd love to hear from you first because I think it's fascinating to know that you are a private practice practitioner and the team that you work with. I'd love to learn a little bit more about that.
Yeah, well, thank you for having me on the show, Aaron. I'm really excited to talk about the subject of chronic cough, which has become near to my heart, and introduce it hopefully to a new population of listeners because so I am a private practice allergist and immunologist. I work at Ohio ENT and Allergy Physicians based in Columbus, Ohio, which is where I grew up. And essentially, our practice, we have multiple specialties within the practice. We have ENT, we have allergy, we have oral pathology, and there's a lot of cross collaboration between the different specialties, particularly in the world of chronic cough between ENT and allergy. And I've already spoken about chronic cough to an allergy patient and practitioner group. And I've also, the podcast that you heard me on was for an ENT group of listeners, for those that are more focused on ENT disease, be they ENT patients or ENT physicians or ENT professionals themselves. So now to be able to talk about this subject with those that might be dietitians or those that are interested in learning about dietary approaches or those who are patients of yours that struggle with this issue is really exciting to me.
That's great. And I learned so much from that episode. I'm actually going to link it below because I think it's really helpful for others to see two different health professionals discussing the
Hmm.
topic as well. Obviously, we're going to kind of approach it from different ways today, but that even that small fact about them mentioning how they've had children who have gone undiagnosed and treated for allergies when they had like some sort of obstruction. I think they said like a popcorn kernel stuck in
Hmm.
their lung airway or something for several months. And that just like was such a good little tidbit of information to think about, especially as a mom.
Right.
You learn so much about the possibilities of potential symptoms and stuff like that. So I'll link it below because it was a really great resource for me. I learned so much, and I'm excited to learn more again today.
Yeah. And some of what we covered today might be a restatement of some things that are in that episode, but I think a lot of what we cover and the majority is going to be something brand new with a different focus and through a different lens.
Absolutely. Wonderful. Well, let's start off with what is a chronic cough because some of my clients are doing more of this like throat clearing, this like
Hmm.
type thing, and then some of them are coming to me and they've even experienced like what I would call like a coughing attack on our calls, which was really helpful for me to see the difference. But can you kind of like break down what it actually is and like what are the most common causes of it?
Sure. For me, there is a difference between throat clearing and cough. To first start out with, just a discussion of those definitions. For me, throat clearing is the sensation of you have something in your throat, and maybe you try and you make some sort of a sound with your throat to try and loosen up whatever it is to get it out of there, dislodge it. A cough is somewhat different for me. A cough is a abnormal movement of air from the opposite direction that it should go. So obviously we breathe in, we breathe out. There's a normal rhythm to how we are breathing in order to move oxygen into our tissues through the deeper airways of our lungs, and then of course moving carbon dioxide and uh, products of oxygen consumption from our bodies out of our lungs and then just breathed out into the world at large. That's normal respiration. A cough is just the abnormal, forceful movement of air from deeper in the airway out through the mouth and out of the body. So a cough is almost like, it's a situation where you're moving air out of your body, but it's not that natural inspiration, expiration, flow process that is indicative of healthy breathing. I think there is a distinction between a cough, which is something that is often uncontrolled, and a throat clearing, which is often something that's like you are choosing to do it because you have a sensation of a tickle in your throat and you're trying to clear something. Now, that tickle might be due to something abnormal, but
Mhm.
it's still a voluntary thing that you're doing to try and, relieve your symptoms versus a cough, which is almost like an involuntary um, occurrence that can happen due to many different factors or many different reasons, some of which originate deeper in the lungs, some of which originate in the throat, and some of which originate above the throat or outside of the throat.
Hmm.
So that's essentially what I would offer as a definition of a cough versus throat clearing. A chronic cough is a cough that's occurring most days for more than 8 weeks in adults or more than 4 weeks in a child. So if you're having that abnormal sensation of moving air outside of your airway from low in your airway to outside of your body, and that's something that you're doing involuntarily most days of the week for more than 8 weeks, that's by definition a chronic cough. An acute cough, we've all had those. We've all gotten sick a few times, at least at this point in our lives, where we've had episodes where we feel like we've had to cough. But usually those tend to resolve on a pretty short time course. You haven't had a chronic cough unless it has really surpassed that time threshold.
Yeah, which I feel like, I mean, personally for me, if I got to that point and I was still coughing, I would definitely see a need to go and be further investigated. Like
Yeah,
I
you'd
would
get
not be
help,
putting
right?
up
Yeah,
for
of
with a
course.
cough for more than that many weeks for sure.
Right.
So hopefully a lot of other people would think of that. But that's so helpful, and I'm so glad that you distinguish the difference between that and throat clearing because I think again a lot of people will just assume some of these symptoms are, what they're experiencing and maybe self-diagnose. So that
Hmm.
it's really helpful to break that down. Now, in terms of the most common causes of chronic cough that you see in your practice, maybe we could break down a few of those. I know that is kind of a loaded question, but um,
Yeah, absolutely. Well, one of the most common causes of chronic cough is what we call upper airway cough syndrome. So we call it upper airway because we think of the upper airway as the nose and the nasal passage and everything that involves the nasal pharynx and that portion of the airway. So what is caused by what when we're talking about upper airway cough syndrome, what we're talking about is inflammation within the nose or the sinuses leading to nasal drainage down the back of the throat onto the throat, which will then force the person to cough. So that's upper airway cough syndrome. And so as an allergist, obviously environmental allergies can cause that problem. Sinus
mhm,
infections can cause that problem. Even chronic viral illnesses or post-viral irritation can cause that exact problem to occur. So that's one of the very common causes of chronic cough that I see. There are other chronic causes of chronic cough. Those would include things that occur deeper in the airways, like lung diseases, particularly asthma can cause a chronic cough. COPD can cause a chronic cough. Anything that aggravates the deep lung tissue and really stimulates and inflames those tissues to produce that involuntary reflex I was talking about before. That's a
mhm,
common cause of chronic cough. And
mhm,
then there are less common causes of chronic cough that are still common, but less common than those two. I'm talking about things like acid reflux, which I'm sure your listeners are very familiar with.
mhm.
Acid reflux, which can occur silently sometimes. You may not even feel that heartburn sensation, but you may nonetheless have reflux going from your stomach up to your esophagus, irritating the vocal cords and promoting cough. And then there are other things that can also likewise originate from the vocal cords and cause chronic cough. You can have vocal cord related diseases that promote chronic cough. And then sometimes chronic cough is caused by um, situations or um, diagnoses that are often difficult to elucidate. And those could
Mhm.
be things like neurogenic chronic cough, where we think it's actually the nervous system that is promoting this cough reflex for some reason or another. So I see that entire spectrum of chronic cough in my practice.
That's a lot.
Yeah.
And I'm so glad that you brought up the what was the word you used?
Neurogenic,
Neurogenic.
meaning it
Okay.
originates from the nervous system.
Okay. So
Yeah.
definitely a big connection, right, between the nervous system and gut health and, the gut-brain
Absolutely.
connection, right? I've talked a
Hmm.
lot about that on the podcast. But
Right.
it's so interesting because I did have a client and she would say, like cold temperatures that would come in really quickly would trigger it. Or
Hmm.
I had one client who said that stressful situations would trigger it if she was like
Hmm.
overworked or things like that. So I would always think of like a nerve situation, and I just did like a very like small deep dive into how you would treat that. like was there some sort of nerve block that treatment that some people do for that? Are you familiar with that at all?
I am, yeah. And there are different approaches to treating it, and
Mm-hmm.
of course, the mind and the body are connected, they're inseparable, right?
Mm-hmm.
So anything that is a stressful or a, anything that cognitively puts a lot of pressure on a person can, of course, manifest itself in the body in different ways in different people. So some people, you're right, might be coughing as a manifestation of some sort of emotional situation or some sort of neurological or behavioral um, uh, condition that they're struggling with to
Mm-hmm.
resolve in that moment. Um, I think what you're referring to, though, is the use of certain nerve suppressing agents for people in ideally in that situation. You've already addressed all of the potential psychological or behavioral factors, but if a person is still coughing because of just some nerve impulse that has been thus far uncontrollable, you can use something like a gabapentin or pregabalin, which are basically nerve blocking agents that you take by mouth to try and slow down that nerve conduction, that innervation of the vocal cords that promote the cough reflex. There are other agents also that can be used for that, some of which are not yet approved in the United States, but
Mm-hmm.
there are other agents that can be used to target that exact purpose that you're talking about.
Okay, excellent. Thank you
Yeah.
for speaking on that. I know it's not
Amitriptyline's
something we
another
had
one.
planned for
Yep.
today, but as I was on my walk this morning, I was thinking like, oh, I really want to make sure we do cover that.
Hmm.
I love that you brought up the environmental allergies. I know a lot of people struggle with that. Even things like mold. Some people are very sensitive to mold. I've had clients who had no idea they were living in a moldy environment,
Yeah.
especially here in Boston. It's like, the apartments that you're living in are just, they're not only like the size of a sardine can,
Hmm.
but they're old. Tenants are not being well taken care of, and these places are not well maintained. So it's much more common, especially around here. um, so some patients are not even aware, and we'll have to either evacuate the facility or get them an air purifier and take other measures. But um, and pet allergies, right? People that are
Yeah, of
allergic to
course.
cats or dogs. So those are all things to think about. What if a cough seems to be only bad at night? I mean, you mentioned environmental, so maybe it could be something related to um, their bed, but I like my brain always goes to, well, are you laying down right after eating? Like, is this
Yeah.
related to some sort of reflux or silent reflux type of thing? Are there other things that people should be thinking about if it's specific to nighttime?
All of those are on the table. Sometimes asthma manifests more so at night with symptoms than other times of the day for
Hmm.
various reasons. I mean, that's one of the things that we track when we're following up patients with asthma is have you had to wake up in the middle of the night to use your inhaler? Have you had to wake up struggling to breathe in the middle of the night? And if so, how many times over the last month or 2 months, etc. So yes, nighttime is, it tends to be when a lot of people struggle with their chronic cough.
Hmm.
That could be related to acid reflux, like you said. It could
Hmm.
be related to some sort of allergen exposure that they're breathing in at night, and it could be related to respiratory disease. So that question by itself doesn't really narrow it too much for me.
Sure, understandable. How often would you say that diet or gut health is overlooked as a contributor to chronic cough based on what you've seen in your practice?
I would say that diet and gut health are overlooked in general in terms of a person's health. I think
Hmm.
that's pretty universal, and I think there's the speed and the evolution of the our approach to incorporating dietary counseling and incorporating some understanding of gut health in at least advancing the future of healthcare. Um, there's a reason why it's happening so quickly is because we're all recognizing how important that is to a person's health. So, in terms
Hmm.
of chronic cough specifically, I would say it's overlooked a fair amount. I don't think it's always overlooked because, like you said, we all have acid reflux and silent reflux and things like that on our differential when we're working up patients with chronic cough. So we will ask them about their diet, how close to bedtime they eat, what are they eating if they're eating late in the day or if they're waking up to snack, things like that.
Hmm.
But I would say that the diet aspect of it is something that is very commonly part of our history taking. The gut health in particular aspect of it maybe That's something that's an area for potential growth and furthering our understanding because that's not something that we classically ask patients about when we're initially seeing them for a chronic cough.
Yeah, that's great. And, I think about this with clients, right? So if we're talking about reflux and LPR, and you mentioned the postnasal drip, right? And so there are so many things that can contribute to that from a gut perspective or even a
Mm,
food allergen or food sensitivity perspective, where patients are eating certain foods or they are engaging in certain types of activities or whatnot,
hmm
or have the environmental exposure. But strictly speaking of diet, there are things that we can eat that could also trigger that postnasal drip, right? And then on top of that, if you have dysbiosis in the gut, that could
right.
lead to those issues with the upper GI system. So having contents, acid or non-acid, going up into the esophagus where it shouldn't be, certainly that could, trigger some of those same symptoms like the postnasal drip that you mentioned.
I think you're spot on with regards to. So let's talk about two separate but probably overlapping things. One is,
Mm-hmm.
of course, the rhinitis, what we call gustatory rhinitis,
Mm-hmm.
which can occur while a patient is eating certain foods. We typically tend to see this in very hot or spicy foods or
Mm-hmm.
foods that are highly acidic, and those can promote what we call gustatory rhinitis, which essentially means inflammation of the nasal passage that occurs while eating.
Mm-hmm.
So, or while tasting, if we're going to be exactly specific about what it means. All right. So, what happens is you eat these foods, they activate certain nerve pathways inside your mouth that then feed into the nasal passage. And then that nerve activation is what drives the inflammation and what will then drive the draining from the nose down into the throat and that upper airway cough syndrome that I alluded to before.
Hmm.
So, absolutely correct. Yeah.
Okay, so tell me this. Why would my uncle tell me that anytime that I have like an upper respiratory cold or something like that, he was always like, eat spicy foods. It's going to help your nasal passages open up. Now, is there a truth to that? Because if you're saying it increases inflammation, is that inflammation a precursor to then like helping to fight the infection, or is that just totally just not relevant?
Yeah, I think there's probably a couple different things going on there. I mean, one is, of course, that eating spicy foods for some people tends to promote this gustatory rhinitis, and presumably they're not already sick when they're doing that.
Hmm.
Presumably they're just living their normal life, relatively free of symptoms, and they eat the spicy food, and then that's when they get this watery nasal drainage. They didn't
Hmm.
have a lot of obstruction to begin with, and the spicy food doesn't cause nasal obstruction, it just causes the drainage.
Hmm.
That's what I'm referring
Sure.
to there. I
Hmm.
think what your uncle, and I would love to have him on the podcast. Also, we could call him up right now, see if we can have a guest phone a friend. I think what he's referring to, and there's actually some evidence to back this up, is that there's the effect of the spice transmitter called capsaicin, if you're familiar
Hmm.
with capsaicin.
Sure.
So capsaicin is sometimes sold as like a supplement or is used as a over-the-counter supplement with numerous health benefits that are advertised for it, but I have seen it be used successfully in treating nasal drainage and nasal congestion
Mm.
in the form even of a capsaicin-based nasal spray. So that's
Really?
available. Yes, yeah, yeah, yeah. I mean, I'm not here to promote that,
No. Hmm.
but there are companies that make capsaicin-based nasal sprays that ostensibly work through that mechanism of the application of capsaicin inside the nose leads to some reduction of inflammation through constricting the blood vessels and
Mm.
through acting on the nerves also and blocking the nerve the sensory nerves themselves can be inhibited by capsaicin. And by
Fascinating.
blocking those sensory nerves, you also open up those airways. That's the idea behind it. I can't
Mm.
sit here and cite data. It's been a long time since I read a paper about this. I will say that every once in a blue moon, I get a patient who either is sick of medication, doesn't want to do anything pharmaceutical, or is really, really averse to ever doing anything pharmaceutical to treat their nasal inflammation.
Hmm.
And one of the things that I can offer to them in that situation is, have you tried intranasal capsaicin? It's all natural. Is that something you might be looking at? And some
Hmm.
patients say yes to that. So
Okay, that's
your uncle
wonderful.
might be onto something. Maybe he's read those papers.
He
Yeah.
does have just like a lot of those. It's kind of like I call it like the grandmother knowledge, where it's just
Mm,
kind of like you don't really know why you know it, but you just know it, and sometimes it works. So
sure.
he
Yeah.
wouldn't have anything to back it up, but other than
Knowledge through
personal
experience.
experience.
Right. Yeah. Yeah.
So
Well,
no,
there's something to be said for that.
yeah,
Um,
I totally agree. And what I think it's so wonderful that you mentioned something here about giving your patients alternatives, because I know that there are some patients who are very hesitant to try pharmaceuticals or even
mhm.
like just over the counter type stuff. I get a lot of pushback in my practice. Sometimes I'll recommend them to patients with inflammatory bowel disease. There's cases where these medications can be really helpful or these supplements can be really helpful, and sometimes it is the best option, but it's so great to know
Right.
that if a patient is looking for a certain approach and they don't feel comfortable with one, that you can offer them other tools to get there, which is so great. I think that's a wonderful thing to have in a practitioner.
Thank you. I mean, I think philosophically that's where we have to be right now. We
Yep.
have a lot of tools. Fortunately, we're living in a time where the number of tools that we have available to treat many conditions is exploding. But the conversation, I mean, we have to be able to practice personalized medicine and not be dogmatic about this is the best treatment, this is the best treatment, or this is the second best, this is the third best, et cetera. It's really all about what is the treatment form that makes the most sense for the person who we're trying to make a recommendation to treat.
Hmm.
And using a conversation with that person, understanding their lifestyle and what their preferences are, and and trying to figure out how does that fit into our framework of evidence-based medicine, and allowing us then to offer them the thing that we think that they're most likely to use and most likely to benefit from, and
Hmm.
that they're also willing to get behind in terms of
Hmm.
adhering to and using on a consistent basis. So yeah, that's my approach, and I think it's an increasing number of physicians' approaches, fortunately.
Yeah, a very
Um,
patient-centered approach.
Absolutely, yeah, yeah,
That's amazing. Can you explain the difference between upper airway cough syndrome and like silent reflux symptoms? Because I feel like a lot of those could overlap, but I could be wrong.
yeah. So I will explain that. I very quickly want to go back to something that I was going to mention earlier that I didn't get a chance to talk about, which
Yes,
is the
please.
dysbiosis of the gut that you had brought up.
Hmm.
So dysbiosis of the gut can, of course, promote inflammation in different distal sites of the body also, not
Hmm.
just within the gut itself.
Hmm.
So, and I'm not gonna say that like we have the best testing now available to diagnose and try and manage that right at the site of the problem, which is the gut. But you had asked earlier about the potential contribution of dysbiosis to upper airway inflammation, upper airway cough. I very much believe that that is a contributor.
Hmm.
Um, but that to me is separate from that gustatory rhinitis phenomenon that I was talking about before. So
Okay.
yes, the dysbiosis, the disrupted gut health, the flourishing of unhealthy bacteria within what should be a native population that is going to promote positive gut health for a person, that can certainly have negative health implications, including increased inflammation in different parts of the body, including nasal inflammation, in my opinion.
Hmm.
Um,
Sure.
yeah, but in terms of how do you tailor a diet to address that problem, that's where you guys come in as
Yeah. And
dietitians.
even like a lot of the stool tests that you can order online that are very popular they claim to like give you a personalized diet based on your specific gut microbiome makeup.
Yeah,
Even a lot of those are promising a lot more than we can do, like it comes out to so much more than just the microbes in your gut.
right.
While we do know there are certain trends and we have this gut microbiome project that can give us so much information about what the general healthy gut looks like, we have to gather everything. Like, of course, you're doing things like a health history, and I'm looking at
Hmm.
things like their diet in very much detail and their stress levels and their day-to-day habits. The gut microbiome testing that we use in my practice is so great, but it's not perfect, right? And
Right.
we're not at a point where we have stool testing that can be used in a conventional medicine setting or that is even recognized as relevant, which is understandable because it's not a diagnostic tool. And we have
Yeah.
to figure out how that could ever be incorporated into a conventional setting, because we all know that the gut's so important, but how do we
Hmm.
actually, have a standard test and then be able to make specific recommendations. But there's so much that we can do through the diet. And, if you're showing low levels of beneficial bacteria, or you have something like small intestinal bacterial
Right.
overgrowth, there's so many evidence-based tools that we can use through diet and supplementation to address dysbiosis, just meaning that imbalance of bacteria in the gut. And a lot of us are walking around with dysbiosis and have no idea.
Hmm.
And that's why bringing experts like you on here to discuss how dysbiosis can be linked to literally everything. It can influence, your upper airways, and that could contribute to things like upper respiratory symptoms. So I'm just glad that we're creating more awareness about it and hopefully
Absolutely.
giving people more tools of what they can do to take it into their control.
And I agree completely. I mean, I think that the we're recognizing the importance of the gut microbiome, and we are formulating an understanding of dysbiosis and what a healthy gut microbiome looks like. But you're right, we don't have precise or precision diagnostic tools, and we certainly don't have interventions that we can literally we can point to and say, okay, if you do this, then here's what the outcome is going to be. Here's what our
Mhm.
studies show. Here's, the likelihood of success, et cetera. We just don't have that data right now. I think what we have, what we can probably take a little bit more confidence in is what you were alluding to before, which is on a long enough timeline, if you do the right things, you're likely to see improvements in your microbiome formulation and composition, and that's likely to lead to better health overall.
Mhm.
And we are trying, people like you and people who are studying this have done a nice job of defining, generally speaking, what are some factors that might promote better gut health in the long run.
Sure.
But yeah, but that's a process that's going to evolve over time. It's not like putting somebody on a course of antibiotics or putting somebody on a course of steroids where you say, I am treating this acute problem and I expect that in a week or two, everything's going to be totally better.
Right. Which can
Yeah,
be very frustrating for patients because a lot of times, especially if they've been struggling for a while, they want those quick results. I'm sure, as
right.
patients, they want to feel better, especially if it's been going on for a long time.
Yeah, especially in our modern society where so many things happen with
Hmm.
the click of a button and 2-day shipping, et cetera. But it's things like that, chronic thing. I think as a general um, rule, issues that are chronic that have taken a long time to develop will take a long time to resolve. Something
Hmm.
that's like a cut that you just typically something that was like an injury that you just sustained over a short period of time will heal up on a relatively short time frame, but something that has been building for years
Hmm.
due to accidental exposure or unhealthy habits that somebody has picked up will take years to really fully address.
Hmm.
So I think people need to go in with that expectation sometimes.
Absolutely.
Now, would
Absolutely.
you
Well,
like me to
thank
answer
you.
that question about the
The
upper
LPR.
airway cough syndrome versus
Hmm.
Yep,
Yeah, that would
LPR?
be
Yeah,
awesome. Yeah, so
great.
if you could just explain the difference between the two and from your perspective and kind of how they're diagnosed.
Hmm. So I think what they have in common is that vocal cord involvement, right? Or
Hmm.
the larynx becomes irritated due to some sort of repeated insult to the larynx or something that is abnormally deposited in it that should not be there, typically
Hmm.
speaking.
Hmm.
So in the case of acid reflux, it's acidic contents. So your stomach houses stomach acid, which has a very low pH, right? It's very highly acidic.
Hmm.
And outside of but your stomach tissue is specially essentially it's set up in such a way that your stomach is able to handle that.
Hmm.
When that acid leaves your stomach or is somehow gets deposited on other parts of your body, whether it's your esophagus, whether it's your vocal cords, those other tissues aren't built to withstand exposure to that kind of acid level.
Hmm.
So what will happen with acid reflux is that it will ultimately, if it affects the vocal cords, that acid will deposit on those vocal cords, and that will have a uh, detrimental effect to the health of that tissue. So the
Hmm.
tissue itself will become affected. It'll become sort of um, corroded by that acid. And over time, that's going to lead to greater inflammation of the vocal cords. And that is going to promote a chronic cough. Obviously, if your vocal cords are inflamed, you can sense that you're coughing. It's an involuntary reflex at that point. Okay.
Hmm.
Upper airway cough syndrome has one thing in common, which is that, of course, you have inflammation of your sinuses of your nose. That inflammation and that inflammatory tissue and mucus will also drain down from your sinuses down to your vocal cords, inflame your vocal cords, and that will the net effect of that is going to be almost identical to what you're going to see with that acid reflux induced cough situation, whereby
Hmm.
you have inflamed vocal cords, you have sometimes mucus and fluids sitting on the vocal cords also, and all of that is combined to create a situation where the body's cough reflexes kick in because the body's saying, okay, I have something on my throat, I'm trying to get it out, cough, 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 or my vocal cords are inflamed. It feels as though I have something on my throat, cough, 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 to try and get rid of it. And you never really get rid of it until you address the underlying cause that is leading to the deposition of fluid or whatever it is, substance on the vocal cords, and that is leading to inflammation of the vocal cords.
Hmm. So in your practice, I mean, what would be your course of action? I mean, obviously you're taking a health history, so you're kind of stringing together a lot more information than just, maybe doing a scope or something like that. But how would you know where to start with a client like this, where, they have this upper airway cough syndrome, but if it could potentially be acid reflux, I mean, what would be some things that you would kind of parse through to figure that out?
Yeah, absolutely. I think you ought to get a great history. Like you said, this is where that starts. You ask about, is there a history of acid reflux? Does the patient have risk factors for acid reflux? Are they a big smoker, big drinker, etc.?
Hmm.
Do they experience heartburn symptoms at all? And then on the other side, do they ever experience nasal congestion? Do they use nasal sprays? Do they use decongestants? We don't recommend that people use over-the-counter decongestants on a long-term basis, but some patients still come in on those medications routinely. Is that something that the patient's doing to suggest that they may have an upper airway component? Do they have environmental allergies? That's something that we always test for.
Hmm.
Well, in certain situations, particularly chronic cough situations, we're very likely to test the person for environmental allergies and try and figure out, do they have these allergies? Is that something that might be contributing to this through that upper airway cough syndrome mechanism? And
Hmm.
if we find ourselves in a situation where the history is inconclusive, or if we think we had the diagnosis right and we've treated the patient for one of these etiologies or the other, and they're still not 100% better, okay, maybe it's time to reconsider. Did we get the diagnosis right in the first place? Were we missing maybe some sort of component of reflux if we were treating them for upper airway symptoms only? And do we
Hmm.
want to add on treatment for acid reflux on top of what we're already doing for the upper airway cough syndrome? Or in an extreme situation, did we really get it wrong? And is this purely just a cough that's driven by acid reflux? We should tell the patient to stop their earlier treatment and start a different treatment instead.
Hmm. Well, I want to come back to the point of like long-term use of decongestants. And I recently had like the worst upper respiratory, like the worst I've ever had. It was only because I couldn't breathe out of my nose. And that's never happened to me where I could not breathe out of my
Hmm.
nose. I couldn't even take a few bites of food and breathe at the same time. And so
Did you
I
try
went
eating
to
like
the,
wasabi or chili peppers or something like that? I mean,
I
did you
should
call your
have.
uncle? Yeah.
I should have, now thinking back on it, like what an easy answer. But the capsaicin, had I known about that, I would have been
Right.
really interested to at least try it because, I was doing the nasal rinses and everything like that
Hmm.
3 times a day. But then for the first time ever, I went and bought an over-the-counter nasal spray, and it said on the label, don't use for more than 3 days
Hmm.
because this could lead to worse congestion. And so then I was like, great, I have a very limited time where I can use this. But I'm now just curious too, because I know from like a histamine perspective, like I don't like to see clients on antihistamines long term, which
Hmm.
is so common that I
Yeah.
see. But why wouldn't someone want to be on a decongestant for a longer period of time? Maybe you could speak to that because I know it's really common when people are dealing with these symptoms, they just start taking these medications and they don't realize maybe there are some long-term side effects.
Right. And the ENT podcast that you listen to, they have episodes that cover this issue. So
Okay,
I will
great.
put another plug for that, for them, for people that want, to really take a deeper dive into this question. But I think when we talk about nasal decongestants, we're talking about two different types of medications. One of them is the intranasal decongestant sprays, like the one that you bought. And that one, with those types of nasal decongestants, we typically tell people don't use it for more than 3 days because of the potential for the body becoming essentially dependent on it. By that,
Mm,
I mean, if you are using it nonstop for longer than 3 days, your nasal passage could get used to the presence of that drug. And
hmm.
therefore, in the absence of it, it's going to become swollen, edematous, and you're basically going to feel like, oh, I need more of the decongestant to relieve that so that I could breathe through my nose again. So that's one of the issues that we run into with that. That's called rhinitis medicamentosa. That's the name of
Yeah.
that term. Yeah.
Okay.
It's basically inflammation of the nose that's driven by the use of a medication longer than its recommended duration.
I mean, this stuff worked so well that I mean,
Yeah.
I felt like I could breathe so well the second, like it 20 minutes later it kicked in, and I just thought to myself, I could see myself wanting to use this thing like all the time. And I actually did
Right.
have a friend in high school who was addicted to nasal spray. Like she was using it constantly. She was fully aware she was addicted to it, but she was, and I just
Yeah.
think back like, oh my gosh, she must be not doing so well with her nasal passages now because of what you just said. That's good
Yeah.
to know.
Well, and there are treatments for it. I've met people like that also. The thing
Hmm.
is that nasal spray works. It's not anti-inflammatory, strictly speaking. The way it works is by constricting the blood vessels inside of your nasal passage, and by
Okay.
reducing those blood vessels, shrinking them down to a certain size,
Hmm.
then that leads to a lot of that fluid, and that fluid underneath the tissue that causes that inflammation to build up, basically retreats.
Hmm.
So that is what opens up the nasal passage. But what I'm talking about in terms of the dependence is that in the absence of that chemical that is inside the nasal spray that constricts the blood vessel, what the body does is, if it's gotten used to it, is that it overcompensates by
Mm.
overexpanding those blood vessels, which sets you off into this terrible feedback loop where you have to spray and potentially spray more and more just to get the
Mm.
same level of vasoconstriction or reduction of the caliber of or sorry, reduction of the swelling and increase of the caliber of the nasal airway. So
Mm.
that's not something, for that reason, I don't want people to end up on that cascade, on that treadmill. So for that
Sure.
reason, I don't recommend using intranasal, decongestants in that way for more than 3 days at a time. But the oral decongestants, the things like pseudoephedrine, Sudafed, those we don't recommend people take for a long time because they also work by constricting blood vessels.
Hmm.
And what that does is that can cause increased blood pressure, increased
Mm.
heart rate, issues like that that are related to uh, the circulation. And so we typically don't recommend that. It's like basically, putting somebody on a stimulant every
Mm.
day. That's over the long run, that's going to cause some problems. I'm okay with people taking it when they're sick for a few days. It doesn't have to be, strictly speaking, 3 days. I mean, if you take it 4 or 5 days, that's
Yeah.
probably not that big of a deal.
Hmm.
But it's really just a matter of, it's not something that I'd recommend that somebody be on for a really
Hmm.
long time. And who knows, maybe it promotes some dysbiosis also.
Yeah, I mean, maybe that's definitely possible. I'm always thinking about how medications impact the gut because most of them do, right? As long as they make their way there, and we have to be thinking about that. Not all are positive alterations, and just
Right.
considering how it's impacting all the systems of the body.
Of course, yeah. The body as a whole, I like to take a holistic approach. I view the body as one whole system. It's not just something where you can treat
Hmm.
a certain part of the body in isolation and never see any effects anywhere else on the body. So
Hmm.
I would argue that it's more likely than not that there is some sort of a gut related um, effect that is taking place if you're taking decongestants on a routine basis, because pseudoephedrine is it's a chemical that's essentially it activates the sympathetic nervous system. So you're going to
Hmm.
have increased release of sympathetic neurotransmitters epinephrine, norepinephrine. You may know them as adrenaline
Mhm.
and noradrenaline.
Sure.
And those neurotransmitters will certainly have effects widespread throughout the body, including on the gut.
Hmm. Yeah, that's a great connection there, and all such important things to think about that most of us aren't probably thinking about.
Mhm.
When you mentioned allergy testing, is there a preferred method that you use, like a blood test or a skin test? And how often would you say that you find in your practice that allergies to food or environment are very common?
Skin testing is preferred.
Hmm.
Blood testing is available, but when skin testing is an option for a patient, we typically recommend skin testing for a couple of reasons. First of all, skin testing, you get your results same day. So you place a skin test, and 15 minutes later, you can interpret the result and be
Hmm.
able to tell the patient what they tested positive to, what their allergies are.
Hmm.
Skin testing is also believed to be more accurate. Studies have shown that you can skin test somebody and their diagnostic accuracy for an allergy is above 90% versus for blood testing, it tends to be closer to, it's in the 80s. So
Hmm.
skin testing is believed to be more accurate and much more reliable for allergy testing. We do test for food allergies and for environmental allergies pretty much every day in my office. I test some people for food and environmental allergies. And probably about a third of the time that I test people, they're not allergic to anything.
Hmm.
Um, many of them are people that are convinced beyond a doubt that they're not allergic, or sorry, that they
Hmm.
are allergic, but it turns out that they're not. So we got to
Hmm.
go by what the testing shows us. And I always tell people that just because you're not allergic doesn't mean you're making up your symptoms. There are other
Sure.
explanations for what's going on with you, and we need to, all knowledge is helpful. So if we know that you came in with these symptoms, we tested you for allergies, and your allergy test was negative, then okay, we need to talk about what other things besides allergies could be driving the symptoms in the first place, and maybe talk about doing some other kinds of testing to look for an underlying diagnosis and a treatment for it.
Hmm. Great. Yeah, that's really helpful to understand, the root cause approach. And it sounds like you kind of go through this process of like checking off the most obvious and potential root causes for people until you basically get to your answer. And there's food sensitivities, and I think a lot of people that come to me, they'll tell me they're allergic to a food, but then I'll ask, like, the food seems like a very obscure food to have an allergy to. Like sometimes there's not like a protein in the food, and I'll just ask them like, is this a diagnosed food allergy or this is a sensitivity? Like, what type of
Hmm.
testing did you do? And they'll say, oh, I did a food sensitivity test, or no, a food allergy test, and then they'll send it to me, and it's one of those food sensitivity tests.
Right.
And I mean, as far as I'm concerned, like I've looked at all the top immunology journals, like they don't support the use of these food allergy or food sensitivity tests. It's not something that I recommend because I often see it do more harm than good in my practice.
Yeah,
I'm curious as to your thoughts on food sensitivity testing.
I agree. I would say use them at your own peril.
Hmm.
People assume that they're validated tests, but they're not, and they're typically marketed in a way that uses language that is very non. It actually, when you look at what their claims that they make, it's very, very vague, and it's not like they're actually claiming to be a test that you can use to guide food elimination. They always say like this may help you in selecting your diet, right? Well, what
Hmm.
does that mean? Anything may flipping a coin could help me decide whether I'm going to have uh, pizza or a salad for dinner tonight.
Right.
So anything may help you decide what you're going to incorporate into your diet and what you're not.
Hmm.
But um, I think that you know, th- there's not a conclusive test that's a lab-based test to help somebody identify their food sensitivities that are not allergic, that don't go through the allergic pathway of your body's immune system recognizing something as a danger and causing an allergic reaction when you
Hmm.
encounter it. I think
Yeah.
the best way to approach food sensitivity, and perhaps, you would agree with me because I refer a lot of these patients to dietitians, is by keeping a food diary and just
Yes.
making notes about, when I ate this, I experienced these symptoms, and
Hmm.
being able to review, okay, what did all of these episodes of symptoms have in common? Oh, it looks like I was eating, whatever it is that day. I was eating cheese. I was eating, beans or whatever it is that could be promoting
Hmm.
sensitivity in a patient.
Yeah, I mean, if a company could guarantee that they could identify all food sensitivities, they'd I mean, these art companies are already making billions of dollars because they're
Right.
kind of
Yeah.
making false claims. But like, if it was actually accurate, I mean, I would be doing these with all my clients. But the true gold standard of identifying food sensitivities is an elimination diet. And
Yep.
that usually starts with a food record so that I can see, like, are there patterns of histamine foods? Are there patterns of high FODMAP foods? Are there patterns of this is actually food you ate yesterday, but you're chronically constipated and it's now
Mm.
finally fermenting in your gut, making its way to the
Yeah.
lower intestine. So,
Huh.
yes, it is food sensitivities. I mean, they can show up, 12 to 24 hours later for some people, depending
Right.
on how fast their motility is. And I have clients who have conditions like high levels of intestinal permeability, right? The fancy word would be leaky gut.
Yep.
But if you have a weak barrier because you are on a low fiber diet or you drink a lot of alcohol or you've got some other health conditions going on that cause you to have this permeability, patients with inflammatory bowel disease on, their medications can actually disrupt this barrier. If you have a imbalance in the gut or you have an issue with the gut lining or the gut's immune function is compromised, you are going to be more sensitive to food. So when clients come to me and they're saying like, oh, like, in the past few years, all of a sudden have all these new food sensitivities, and that could be related to hormonal changes and it can be related to gut issues. So it's really so important to work with a dietitian when you do this because it just can go so wrong and you can get to a point where your diet becomes so limited and you're not even really teasing out what is the most important to be cutting out, and then also try to reintroduce the food, right? A lot of people just kind of write it off and say, well, that must have been it, so I'm never going to eat this again, versus, okay, let's do a real experiment, do a proper elimination, then a proper reintroduction, and get the patients to really understand like what types of symptoms we're looking for and what the nuances of the reactions could be, because it's so complex. And that's why, I always advocate for healthy relationship with food. And we know that
Hmm.
with the gut, we want as much of a diverse diet as possible in order to feed the good microbes and get the nutrients that we need for optimal health. So being on a more restrictive diet is the last thing that we want for
Totally agree.
clients.
Yeah. Yeah. It breaks my heart when I get patients that come into the office and say, I've cut out, almost every food under the sun and all I can eat is chicken broth and bread and I'm just, or rice and, rice and whatever. It's almost like, when a patient has just taken that, when they've had one negative experience with the food and they've decided, I can't have this food now, I'm allergic to it. And they've done that over and over again until they've chopped down almost everything in the world that they can eat. Yeah, then that's also going to cause them to have more problems as they continue with their healing journey. So,
Sure.
yeah, so that's, and of course, it's no way to live your life, right? But
Yeah,
it's really cool to hear that you're taking into consideration all of those different aspects, things that I hadn't even thought about, like active fermentation in somebody who's,
sure.
in the gut, in somebody who is a slow transit motility person. That's,
Yeah.
that's something to really think about. If somebody's having delayed symptoms, maybe long after a meal, is it because of something they ate a day or two ago, and
Mhm.
their motility is such that it doesn't affect them until after we would have we would have otherwise thought about that being a potential problem for them.
Yeah. Yep. Some clients are very in tune with their bodies, and I am someone like that. So like when I was in my gut healing journey, I could pinpoint like it wasn't what I just ate, it was what I ate the day before, but that took time and that took
Yeah.
food journaling, because I for so long in my journey I was like, I don't want to log my food. I've been doing this for so many years to become a dietitian. And but once I finally did, that's when I finally started getting answers and realizing like, oh, it's not dairy and it's not gluten, like the things that you see online of like, these are the things you should cut out. And it wasn't, it was like, oh, kale causes me to have a
Mm.
lot more bloating, but it doesn't happen right away. It's the day. So I love learning about that aspect of gut health because when I get to explain it to clients and empower them and not be so afraid to then try to reintroduce foods. That's my favorite part of my job, honestly. I would say that's probably one of the top.
That's one of my favorite parts of the job also, both with food and with medication. I
Yeah.
mean, being able to tell a patient that they're not allergic to a food anymore and they can reintroduce it into their diet, or that they're not allergic to a certain medication that they've been convinced for years that they have a serious allergy to, and they can
Yeah.
get it if they need it or if they can get it, to treat something rather than depending on inferior medications.
Mhm.
Those are very good days in my job. I'll
That's
put it that way.
awesome. That's
Yeah.
great. Well, I know we're really coming up on the last minute here, but just in like a big general term, I mean, what would you say to somebody who's struggling with chronic cough?
hmm
Are you accepting new patients? Like kind of give me a rundown on that as well. But what would you say to someone who's been struggling with chronic cough for years?
Yeah.
Maybe they're feeling really hopeless or defeated, or hopefully they've even just taken a good amount from this episode. But what would you say to them?
Well, first of all, I am accepting new patients. I think that allergists and immunologists are often overlooked in terms of the management of chronic cough, but we can be some of the most important physicians because our specialty, we have the ability to treat the wide range of conditions that cause chronic cough.
Hmm.
Regardless of where that chronic cough originates from, we are asthma specialists also, so a lot of our chronic cough patients are patients with low respiratory disease, and we can identify that, and we can identify many of the other things that could be contributing to a chronic cough. And we're always thinking about what are the tools to treat chronic cough and what's on the horizon in terms of new tools that we're going to be able to have to treat patients with chronic cough of different etiologies. But somebody who's been struggling for a long time, I know it's challenging. It's like I said before, if basically there's a correlation between how long you've been dealing with something and your time to resolution, unfortunately. That doesn't mean that you should give up. Just because something has been chronic and it's been uh, something that you've learned how to live with, if it is really impacting your quality of life, it's worth seeking another opinion, getting additional perspective on it, and seeking really not only just the opinion of various specialists, but trying to identify one specialist or one person that could be your primary care physician to be the quarterback of your treatment for that particular condition. So I would say don't be shy and don't hesitate at all. And don't be afraid to ask the person that you're seeing who's going to help you address your chronic cough. Hey, I need somebody to be my point person for this particular condition that can really help me address this and not give up. And, even if there are other specialists involved, can be involved in the coordination with the other specialists and reviewing what my treatment plan is with these other specialists that I'm working with in order to
Hmm.
help me address the root of the problem and hopefully at least make it manageable, if not fully eliminate the problem. I think
Hmm.
the vast majority of chronic cough patients will improve and the cough is going to go away if they're treated appropriately, if you get them into the right hands, and if you have somebody there who can really steer them in the right direction by synthesizing and putting together everything that they have been through on their patient journey and giving them the most appropriate plan for them. And
Hmm.
I think one of the gaps that we often run into in our healthcare system now is that there are a lot of specialists, and therefore the responsibilities just kind of gets passed around individually, and there's never anybody bringing together all the strings and saying, okay, here's what all of these different tests and treatments have shown us about your situation so far. Let's use that, let's put that together, and let's, take what we've learned, both the good and the bad, the what we've learned in the negative and what we've learned in the positive about your condition, and let's chart a direction as far as how we're going to address this problem moving forward and what our backup plans are going to be if the next step doesn't work. So that's my final take home message. Find a quarterback for your chronic cough. Work with your multidisciplinary team. Your dietitian is hugely important in that it can be in a lot of these situations. Don't forget about them, but also don't forget about the allergist and immunologist, the primary care physician, potentially the GI and the ENT physician and the pulmonologist that may be involved in resolving this problem as well.
Yeah. Yep. That's well said. That team approach is so important. Anyone that wants to try to do it all isn't doing you a service, right? They're doing you a disservice. And I'm always like Googling and researching and even trying to find like providers for people to try to help them because there's only so much that I can do. But I think one of my favorite things is that I can build a network of people like yourself that I
Yeah,
can have in my repertoire that I can recommend to people, because that's what we're here for, right? We're supposed to help each other, build each other up,
absolutely.
find each other good quality people in the field. And so thank you for the work that you've been doing. It
Yeah,
is
thank you.
undoubtedly making a huge difference in the health and wellness field, and especially these patients that, have been struggling for such a long time.
Yeah, and in the health professions, it's our responsibility to do that, both nationally and locally, building those
Right.
networks. So I look forward to using you as a contact also, Aaron.
Awesome. Well, thank you, Basil. Can you tell us where people can find you if they are looking to get in touch with you?
Sure, probably the easiest way is through LinkedIn. So you can just find me. It's just Basil Kawash, MD. You could search that on LinkedIn, and I'm sure you could post a link to my profile
Yes,
also
I
in my bio
will.
here.
I will most
And
certainly.
happy to connect with any of you there.
Thank you very much. Well, thanks so much for coming on today, and I look forward to everyone enjoying the episode.
Thank you.